But I want to thank you for this opportunity to kick this off. First, I do want to thank the ASH&R members here for inviting Qure to participate in this great learning event. We're honored to be a platinum sponsor for your event this year. So today, Dr. Lobo is going to talk about innovation in AI, for stroke and TBI. Some big realities that we understand, your profession is facing today, are things like, study volumes are increasing. They're getting more complex. There's a shortage of radiologists and perhaps even maybe fewer radiologists graduating out of programs today than in the past. And then of a big concern is burnout. And it's something I read about all the time. So, how can AI help today? Maybe in quality improvements, turnaround time, efficiency gains, smaller things like automating tasks and calculations, probably to even bigger things, like mitigating institutional risk. So let me give you just a quick 1-minute overview of Qure. What you probably don't know is, we're in over 50 countries. We've processed over 4 billion images worldwide to date, and we have the largest AI footprint in the world. You'd never know it, but we do. We're an AI platform with many offerings. We're not a one-trick pony. We've been in business for 6 years. We're well-funded. We're PACS agnostic. In fact, we're offered on many PACS platforms or their marketplaces today, and even through Nuance as well. We have about 40 peer-reviewed publications and solid clinical evidence to share today, from Mayo to Harvard to other ongoing research that we have. And our neurocritical care suite that Dr. Lobo is going to talk about today is FDA cleared, does ICH detection, measurements and quantifications in 12 different subtypes. We help to triage and prioritize these findings and move up the study. We even have things like progression monitoring to automated aspect scoring. So my one request after this presentation, if I could ask, is we want to give you the keys to test drive this application. Please do download the app. We have the QR code embedded in the presentation. We even have it outside on paper if you want to scan it. It's free. Just register. Look at some very compelling cases. See how the AI works. And you can even upload cases if you want to do that too. And we're going to show you at the end how easy that is to do. But I think you'll see a lot of value in the utility of the product and how well it works just on trying it on your own. Thank you, everybody. Dr. Remy Lobo.
Thanks much, Mazen. We appreciate it. Please scan QR codes. It's my fault you're going to see this QR code 20 times in this presentation. It's because I was like, everybody should have a chance to do it. Click, easy, schedule, sign in. It's super, super easy. Okay, so the first thing that I'll say, and Mazen alluded to this, is that, let me go back. Here's my spiel on AI. AI is not something we should fear. I will take Wiggins' statement about this. It will make me a better radiologist. The whole goal of AI is to make us better. I think back to mammographers in the world of MAMs, and they would click through their study, and they would get to the end of it, and they'd be like, all right, I think I'm good. I saw it all. And then the CAD pops up, and they're like, let me look at that one again. And look again and be like, okay, either it was fine, disregard, or, hey, that was good. Now I see it. And then we are all learning. So we are all here to learn. We can all learn from everybody, including some computer programs, and that's okay too. I'm pretty agnostic in who I learn from. So that's the part. Mazen mentioned Qure.ai is not a one-trick pony, and I think that's a really great analogy. It's not just the QER program, which is their neurocritical portion of it, but keep in mind there's a chest x-ray application embedded in this. There's lung nodule detection embedded in this. There's fracture detection embedded in this. So when you're looking at platforms to adopt into your institution, to try out, know that you have an outlay to get into them. And once you step into it, what do you have available to you, right? I don't want to have to pick one thing for stroke and one thing for nodules and one thing for CTs, another for CTPs and another one for, you basically want to see if you can one-stop shop. And if you get in with one, you can basically open up to their world, their suite of applications. And that's something that Qure offers an opportunity for you. So just make sure that when you step into this, you're stepping into more than just one thing. So I'm going to talk about one, but there's a lot more than that. So Mazen mentioned the numerous patents, publications, number of countries that they're in. I think the article that is most relevant for us in the neuro realm is down here in the Lancet. Basically, they took their algorithm, they applied it in head CT scans to define these critical findings, to show the validity of these findings, its ability to detect, to triage, and that's really what we want, right? You want it to flag the positive studies, pull them to the top of the list, and then it does embedded layering of critical, next critical, like it's pulling things up to the top. So on 40 head CTs in the morning, you're going to knock out the 3 hemorrhages you got to call, and then the shifts and things like that. So those things are going to come up and take care of your calls fast and early. Maybe you've seen AI in the media. I think it's a thing. It's no shortage of publications that are out there. They've been fortunate to be mentioned in a lot of different places, including Aunt Minnie, who we all get those texts and emails from Aunt Minnie regularly, and this little publication called New York Times. I don't know if you've heard of them, some startup, I think. So we use Sectra at Michigan. So for us, it's useful to know that they're embedded in the marketplace. So within Sectra, you have this ability to work with their maybe like pre-selected vendors, if you will. They're kind of the ones that have already shown an affinity to integrate in with Sectra. And so that's a useful thing. But the benefit to Qure really is that it doesn't care. It doesn't matter what packs you have, because it's playing with your DICOM data. So as long as you're pushing DICOM data to it, it can give it back to you. If you want to embed it in your system, it is nice to know that these links already exist. Rely is the Fuji version of this. They work with a whole bunch of people. Obviously, you see Qure on that list as well. So it's good to know that the major PACS dealers are aware of it and are not only growing their in-home programs, but are saying, hey, you do this better than us. You have focused on this. You've adopted 6 years into this. We're just learning about it. So they're taking and leveraging experience and sharing that with you. Blackboard, another program that some of you may know. What do I care about is I care about how my life is easier. So I wear a headset dictating. I use a foot pedal for my microphone. And I love things I don't have to talk about. And the fact that it integrates into PowerScribe is a very big deal for me, because I don't want to have to measure things. And I don't want to have to report things that I have to measure, because click and drag, right? A radiologist with a chance to measure is a chance to do harm. This is like giving you the data, saying it's same, better, worse, and then if someone wants the proof, you got the proof in the pudding. So the fact that it integrates with PowerScribe is a really valuable tool for me, because it makes my life easier. Did I say I like my life to be easier? I do like my life to be easier. So most of us at these types of conferences tend to be, in the world of radiology, we tend to skew a bit to the academic realm. And that's okay. I think there's something to be shown there, but also it's important to know what the vast majority of our colleagues are in the world of private practice. And VRAD, of course, being a huge private practice group, has a large number of hospitals. Maybe they're in your hospital too, and they're interpreting millions upon millions of images. And I think it's important to know that a company like Qure has been vetted by VRAD and is being used by VRAD, and that's a really powerful feature, right? I mean, one of the reasons when you decide if you want to buy something, what's the most powerful tool? Word of mouth, right? And that's a really big mouth. So say what you want about VRAD, maybe you're pro or anti private equity or third-party vendors, et cetera. To me, that's a huge endorsement. Someone they trust. I think that's a gift. So let me take you a little bit through the product so you can kind of see what you have an opportunity to see when you download. Scan the code, log in. It's like 20 seconds to give them your email. They're not going to give you 1,000 emails saying, look at me, do this, sign up here. It's fine. Log in. It's super, super easy. Okay, so what are we looking at? There's a bunch of different areas that they're going to test. They're going to look for bleeds, they're going to look at vents, they're going to look at fractures, strokes, shift, mass effect, and gas in the head. And these are things that we're all going to report on our studies, right? So there are multiple sites that are doing it, a lot of scans that they're running. So we'll look at the traumatic brain injury column and kind of take you through that first. So it's looking for different types of hemorrhage. So not only does it say hemorrhage, but it tells you where that hemorrhage is. High AUCs, right? Anything above 9, 9.5, 95 is terrific for an AUC. it gives you a pre-filled template. So when you're inside the app and you're looking at it, down at the bottom of it, you'll see a thing that says report. You click it and it shows you the report. And I'm not lying. You could like copy and paste that into PowerScribe. Like, yay, just yay. Okay, sorry. That's like a gift. Okay, anyway. Quantification of shift. So not only saying that there is midline shift plus minus, but actually giving you a value of the midline shift. I don't have to click the keyboard shortcut to pull out the measuring tool and draw the line in the front for the folks and then measure how far over and then do that. And then I have to delete it because it sticks on packs, and if the next person opens it, then they got to see my measurements. Just make your life easier. So it's awesome that it's measuring the amount of shift as well, right? That's powerful. There is this thing called aspects. Maybe you've heard of it. I report aspects in my reports, and I think that we should in every case of suspected stroke from the ER. I do call the ER to get the NIH score as well, because often it's just acute TPA and it's really fell and hit head. So when you get the right clinical history, aspects matters. It matters in triage, it matters in who gets intervened on, and I think it's important for us to give that information. This will give you an aspects score, and I think that's important. So these are a couple cases, kind of case examples of what it's finding. So you see the small amount of subarachnoid hemorrhage here, subtle on a fast day. Maybe you see it, maybe you don't. There's clearly something happening on the other side too, so maybe it increases your threshold, but it's proof of concept, right? This is a place where you often see streak artifact in the skull base. We can get burned here. Yeah, we can get burned here. So it's nice to know that someone else is helping back you up. And that's really what you want. You want someone supporting you and elevating you. That's why we are here. We're here because we care about each other. We want us all to succeed. It's not a zero-sum game. Small hemorrhages along the falx. These are really subtle, hard to catch. Flagging these kinds of things are important. Maybe you disregard this. Maybe this is calcification from 6 years ago. But if it's not, it's new, and some program is telling you, hey, look at that again. You're going to see that, and you're going to say, hey, you know what? I maybe would have disregarded that and not the right clinical history, but when it comes to you with a different bias, you change that sensitivity, and I think that's what we really want to give you. So the hello flies. So one of the things it's looking at is the quantification of these progression monitoring reports. So you have to know what it's looking at. So this is a 2-page slide. I'm giving you the first page right now. So here's what it's measuring, right? This is a day in October. This is a couple days later. This is a few days after that. And it's measuring hemorrhage. It's calling it hyperdensity. Oh no, that's hemorrhage. So it's measuring how much density is there. How much is there? How much is there? You see it getting smaller. We know the hemorrhage is resolving. Okay? Nice. Shift. You see shift that's present there on day 1. Similar, less. Vents, how the vents do, and as the hemorrhage goes away, the vents are going to compensate. And so what it's doing is you can see what it's flagging, what it's measuring, and then it gives you the output. So your clinician, neurosurgeons can say, hey, you know, hemorrhage getting better, we like this, we have the proof and the concept. They can tell the patient, look, 80% of the stuff is gone, you're okay. The shift getting better, vents compensating and coming back to a more normal balance. And that's kind of what you're looking for from the clinician standpoint. I see this valuable tool here. We do a lot of shunt CTs. Maybe you have neurosurgeons that like to place shunts and see how big the vents are because they can't just eyeball the patient and be like, same. So they do these head CTs and you're looking again and again. Are they a little bit the same? Are they a little bit bigger, smaller, whatever? This gives you the number. You can be like, it's basically unchanged. You can see that it was X, Y, Z. It's fine. It saves me measuring. So this is an example of aspects, right? So you have a patient showing up, they have some NIH score that you may or may not get coming across to you, but at least you have it flagged that the M3 and M6 zones are hypoattenuating. And so you already know you're losing 2 points off the top. These are easy things to push into and know that we're finding abnormalities, we're flagging abnormalities, and we're pulling them to the top of the list. These are the kinds of things you want to come up to on your lists fast. One of the things I think is valuable in these platforms is the integration. Is the integration. You have patients that are popping to your list. You can scroll the DICOMs in the application. You can actually notify other teams. So depending on the profile and groups you have set, let's say you have a CT head group that's notifying, it can notify the entire neuro ICU team. Like saves me picking up the phone and calling. We have reading room coordinators at Michigan. Don't judge. It is nice. If you don't have them, highly encourage it. It's basically like a computer helping your reading room coordinator too. So I'm okay with that. Page away. It's all good. They're not paging me, right? I'm paging other people, so it's just fine. And I think the templates are really valuable. I mentioned this embedding in PowerScribe. That's a gift, right? How much do we struggle with the ultrasounds and the 7x3 by 8x2 by 9x6? And I have to say all that garbage to get it in the dictation. It does it for you. So one of the things to know is where you are in the pipeline with Qure. So right now, the FDA is cleared for the non-contrast head CTs, and this is where they have put a tremendous amount of time, energy, and money, right? This is where they're putting all their work because anybody can get a head CT, right? Any place that has a CT scanner is going to run a head CT. They're not always going to run a CTA. They're not always going to run a CTP, but they're going to get a head CT. They're going to get flagged, transferred into your system, and you're going to know before they hit the door how to triage. And that kind of early activation, that activation of the system before they even get to your hospital is really, really valuable. By focusing on the non-contrast head CT, they lower the barrier to entry, right? If a radiographer can do a chest radiograph on the floor, they have to be able to do a head CT. They don't have to be able to do anything else in the CT scanner, just click the head button. And that kind of low barrier to entry, I think, is really important. So where are they now? Primarily head CTs, but keep in mind that there are more things coming. The aspect stuff is already there. You have large vessel occlusion indicators on CTA, CTP, which are going to flag through. So those are kind of in the pipe. But where does everyone start? We all start with a head CT. It's basically how you show up to our ER. You get a head CT, chest x-ray, and a CT abdomen pelvis. Is that like the order suite for you and your ER? It's all of our orders. Okay, so where's the validation? Where's the proof? This is the proof. You want articles in journals you've heard of. I've heard of this one. There's some folks here from the UK. It's this small little startup called The Lancet, which is pretty great, right? They took a bunch of data sets looking at head CTs, 20,000 cases with radiologists report as a ground truth, which we appreciate being called the ground truth. That's very nice. And using multiple radiologists to assess it. High AUCs, basically showing that the product works, right? You want something that works, that's effective, and that hits. And so that's kind of the gold for that, right? And that was done in conjunction with Mayo. I've heard of this one too. It's somewhere out east in Beth Israel. And again, looking at head CTs to measure the size of lateral ventricles. This, I think, is making life easy for us, but also making life easy for the neurosurgeon. When the neurosurgeon is talking to the patient and patient family, when the shunts are in, saying, hey, we have to have you back to do this, maybe we need a revision, maybe we need that. They look the same to me, they look the same, or I think it's fine. The neurosurgeon can pull out that automated report showing you the yellow and the red, or yellow and the green, and being like, your vents are bigger. Here's the picture. They were 83 and now they're 92. Come on, like patients sometimes need convincing. And I think we have to also understand that as we help patients, there's a convincing portion to help there for our clinicians to help their patients too. And I think that's a nice point. Triaging, I think anything that makes it easier for us to notify other clinicians is valuable. This is added value, right? So it has to be accurate and it's got to get to other people fast. So no matter how you're driven, there's a way for this to help you. Okay, so if you're risk driven, this can embed in your risk and pull things up the list, right? So you walk into 40 head CTs, I kind of alluded to before, 3 of them are going to have hemorrhages, let's say. Boom, pull them to the top, notify and done. The next ones you want to see are the shifts, right? So it's going to pull those up to the top of the list, notify out the shifts, the increasing shifts, the increasing vents, the changes that are, marked, new subdural collections. It's going to catch all those, pull them to the top of your list. And then those are the ones that are already in play. The infarcts on non-contrast head and LVOs are also in the pipeline. They're coming out too. And then you have to know that it's accurate. So, is it accurate? Yeah, it's accurate. These are the measurements you're looking at, the differences. They're not a big difference. So basically, it's not measuring inappropriately. When it's measuring a lateral ventricle, it's measuring the lateral ventricle. When it's measuring midline shift, it's measuring midline shift. And it's about what I would measure. And that's kind of what I'm looking for. If it's within a millimeter, that's basically how big my thumbs are. So it's okay. There are a lot of different people that have partnered with Qure. This is regarding the brain scan for AI. This is a neurosurgeon at Cooper. And basically what they're looking at is getting faster to diagnosis, to triage, and track. And so these are the kind of the cohorts they're building from the neurosurgical side to see who they can see, who they have to target, and who they want to follow along. So I think that's like a very important component to this. Yeah, that's nice. And obviously, we still love Aunt Minnie. I don't know if you remember Aunt Minnie when you were residents. It still holds true for me as a faculty as well. One of the things I didn't think about much was the gaze deviation. So patients who have dysconjugate gaze on head CTs, you can actually look at that, measure that, and some of the neurosurgeons have actually looked at gaze deviation. These are people who are doing mechanical thrombectomies, right? So they have a keen interest in this. They've looked at the gaze deviations as a kind of early indicators of LVOs. And keep in mind, again, they're investing tremendous time and energy into the non-contrast head CT realm, right? This is what everybody gets up front. It gives you a chance to take that data. It doesn't matter what hospital is doing it, but to take that data, process it, have it hit your list, drop a report in the system before the patients hit the door. The critical teams are activated that need to be activated, and interventions can be coordinated. So this is one that basically was a proof of concept looking at the subdural hemorrhages and showing that the AI is proving what we know. The shift in midline decreases with increasing age for similar volumes of hemorrhage. So it's quantifying the amount of hemorrhage inside a head, it's quantifying the amount of shift, and it's correlating it with age and basically showing you that as a patient ages, which none of us are doing, but as patients age, we have a little more space in our head. We can fit a little more subdural blood in there without the shift. And we kind of know that, but it's nice to see this as sort of showing you that it can measure across ages and it doesn't matter, right? It's not based on age, it's based on the anatomy, and it honors the anatomy, and that's what you want from a system. So clipped picture there. This is an interventional neurologist from Barrow, and they're basically looking at, so this is kind of like the future, what's coming down the pipeline in the next year for Qure. This is one looking at the head CTs, looking for LVOs off of non-contrast head CTs. Basically, anything that can decrease time to thrombectomy is golden, right? Brain is time, time is brain. So getting the patients quicker to mechanical thrombectomy, getting them quicker into the suite so they can be activated and intervened on in intervenable cases is what we want to do. It's what we're trying to facilitate. And anything that helps us do that is a win for a patient as far as I'm concerned. And that's what they're doing at Barrow. So I think it's fantastic. So this is another neurosurgeon who does mechanical thrombectomies. They're looking at, again, mechanical thrombectomy eligibility and looking at the criteria for that. So just looking at the clinical information and the infarct aspect scores, you can actually get better triaging into what pathway those patients are going to get. There was a contrast shortage recently, maybe you heard about it, and one of the things we really didn't stop doing at all was CTAs, but there could become a time when maybe CTPs are at risk. Maybe we're short contrast because of another whatever event somewhere in the world. It's nice to know that there are ways to create intervenable situations without needing as much contrast. And sometimes patients just don't tolerate contrast, so that's a nice thing to know too. This is a physician who's in Providence, Rhode Island, basically looking at time to activate the cath lab. And I think it takes time for our neurosurgeons, our rad techs, our nursing to get in. So the quicker that you could pull them in, the faster you can get a needle in the groin, the faster you can get a catheter in the noggin and rip that clot out. And that's what we want, right? We want patients to have no clots in their heads. And anything that makes that faster is a win. So I think that's really valuable. What I mean is you have an opportunity here to just get the teams activated faster. And this is working in the background in parallel with you and making us better. So looking at the triage, basically they can assess different volumes of trauma, look at the underlying lesions. This is a study done with Cooper. You're trying to give patients prognostic information, looking at what is the degree of burden, where are the injuries, how much brain is suffering, and can that be used as a counseling tool with patients? Can it be used as a triage tool? Where are you sending them? Are these going to the neuro ICU? Are these going to step down? Are they going to the floor? It kind of gives the alert teams the appropriate way to triage those patients, get them admit them, get them out of the ER, There's 150 patients in our ER, so the faster we can get them out and up to the floors, the better it is for us. Knowing their destination matters. And this facilitates that, right? It's not doing it for you, it's facilitating us to help move these patients along. And I think that's the gift. That's kind of what we're looking for here. So this is your homework. Please scan, please download. Mazen and his team are here, they're out in the lobby, and I highly recommend you sit down with them, you talk with them, and give them an opportunity to show you what they have. That they have given you the keys to the car, right? This is PACS agnostic. You basically click a button, click the files, release. Please remove all the HIPAA information from it. But if you can anonymize a data set, you can trial this out, right? You don't have to know computer programming. You don't have to make 7 different logins and authenticate off 9 systems. Basically, take a data set, anonymize, drop. Click, drop. It's that easy. And you can see it. You can validate it for yourself, right? They are basically giving you the keys to the car. I'm not telling you to take your entire work list and process it through here, because that's kind of cruel, but maybe it's okay. It's not just one thing, right? The head CTs, share it with your chest colleagues, share it with the MSK folks. It's really, really easy to do. So that's kind of what I wanted to give you an opportunity to see. They're letting you trial this software for nothing. That's how much they believe in the product. And I think that really speaks to where they are. Thanks.